Hello, I'm Dr. Terry Treadwell from the Institute for Advanced Wound Care in Montgomery, Alabama. I've been asked to talk with you a little bit today about pressure injuries. We know that pressure injuries are very common, especially in this time of COVID, and we'll talk a little bit more about that in a little bit. But mainly we focus on prevention, but we're sometimes overlooking treatment a little bit as we go through, since we're trying so hard just to prevent these things, but we do know that a number of these do occur. The burden of pressure injuries is fairly significant. As you can see from this slide, about 10.5% of people who are hospitalized will suffer a pressure injury. I think in the recent times, it's been significantly more. Nearly everybody that's been in the hospital in our area with the COVID, especially if they've been on ventilators, have come home with some type of pressure injury, either heels or presacral area. It has really been a major problem for us to treat all of these patients as they have successfully gotten out of the hospital. We do know that the rate of infection of pressure injuries is about 6%, as you can see from the slide. Again, as the picture shows over on the right-hand side, it shows that pressure injuries are the most common location in the presacral area, and that's mainly because, at least especially in the time when people have been on ventilators and all, they're lying on their back and they are having a hard time offloading that area. The rate of incontinence that we see in hospitalized patients runs about 80% or so. This doesn't help matters because you know that it maintains the moisture and the chemical injury to the skin as well. So that increases the burden of pressure injury. They talk about pressure injuries being a never event, and indeed they are considered a never event, but they're the only ones that are considered a never event that seem to be increasing in incidence around the country. Pressure ulcers and pressure injuries, as you know, are very difficult to manage and difficult to prevent. It takes a lot of attention to do that. So once we develop a pressure injury, where do we go from there? There are many methods of treatment, and you can see that, and I don't mean to insult anybody's intelligence as to outlining all of this, but if you look on the left-hand side, the list there is rather inclusive. Pressure relief obviously is number one. You want to get people off of these pressure points, pressure areas, so that the body will have a chance to heal and certainly not develop any more problems. Infection control and debridement pretty well go hand in hand. We know that if you leave a lot of necrotic tissue there, then the chance of infection goes up. But all of that has to be managed as we look at the patient and try to manage the pressure injuries. As listed next in that list, the dressings and topical agents, as you know, there are a number of them there. And the chart on the right-hand side tend to indicate when you can use those. Obviously, each one might have its location. Gauze dressings apparently are still number one on the list of dressings that are used to treat any kind of a wound or an ulcer. But again, we know that they're not the ideal dressing that we want. Alginate dressings, foam dressings, hydrocolloid, hydrogel, all of these have their places. Hydrogel, of course, are especially indicated for patients who have dry wounds that need to be moisturized. Silver-containing dressings and honey-containing dressings are those that are designed to try to keep the bacterial content under control, or perhaps even treat any infection that might be there. Obviously, I would suggest that you be very careful with those because many of the silver-containing dressings have enough silver that they will treat the bacteria there, but in addition to that, they sometimes can slow healing down because they can be toxic to cells. So it's really careful to contain your use of silver. If you need it for an acute situation, then use it for an appropriate period of time. And then I would suggest moving on to something else. Honey-containing dressings do have mild antimicrobial effects. There are some new honey dressings that are coming out that may be more effective, but we'll look to see that in the future. The transparent dressing film is noted in the chart there as being a barrier from body fluids, and there's no question that it is, that it will keep the body fluids from getting into the wound. But remember that these things are impervious both directions, and for the most part, they will trap fluid underneath them. So if you have a draining wound, you're going to have a lot of problem with contained fluid under there. So I would encourage you to be very careful about using the transparent film dressings. Negative pressure wound therapy, everybody has their ins and outs about when to use negative pressure wound therapy, especially in pressure injuries. I'll leave that to you to make that decision, but they can be very useful. That therapy can be very useful in patients who have what I call deep dark holes. to help fill up the injuries that are there. With the newer types of negative pressure wound therapy, there may be some other options as well. Other therapies, there are new therapies that are out there being developed and are coming along. We don't have time to discuss those, but maybe at some other time we could discuss the newer therapies that are available out there. Patient optimization is an important part too. As you know, we need to control diabetes, control blood sugars, things along those lines. In the patient with a pressure injury, many times you need to be aware of their nutritional status and other things that are going on with the patient. You treat the underlying conditions, as we say, in addition to the hole in the patient. But as we look at the list and we look at the information that's on the slide, the box at the bottom talks about the therapies that are available, but none have been the golden bullet or the home run hitter that we would like, and that's certainly true. We're still looking for an ideal treatment for these types of problems, but for right now, we'll deal with the ones that we have and see what might be the best we have. These are the international guidelines and recommendations for treatment of pressure injuries. I'm sure that all of you have seen these. You can see the hydrogel, hydrocolloid, and other bandages and dressings are used for ones that are just not draining much and certainly are not colonized with bacteria. You can see in the second bullet point, the ones that are indicated for patients who have draining wounds. Then negative pressure therapy in the third category. The topical antiseptics are ones that are now being recommended for the treatment of bacterial overgrowth or colonization. People don't like to use topical antibiotics because of the risk of developing resistance to the organisms, and we're seeing that more and more. So something that you can use that will get rid of the bacteria but still not cause resistance is important. The topical antiseptics seem to be fitting that bill, at least at this point. Many of the topical antiseptics, as you can see in the next bullet point, are effective against biofilm. Biofilm is something that we've noted to be more important recently, and it is something that needs to be managed. Topical antiseptics that will penetrate a biofilm and manage the bacteria are good things. We also need to combine that with some type of debridement to remove the biofilms that are still there and prevent their recurrence. All of this will be beneficial. And it seems like hydrochlorous acid seems to fit that bill fairly well. The hydrochlorous acid that obviously we're mentioning today is the Vosh wound solution. One of the things it said was about compromising in our treatment of our wounds. The thing that we're looking for is the best treatment that we can have, but something that doesn't cause problems or damage. If we're looking at a solution or treatment that's completely safe, it may be very difficult to find because many of them have some effects that will perhaps damage cells. I already mentioned to you about silver, the long-term use of that, slowing wound healing and being toxic to the cells. Many of our wound cleansers can also be toxic to cells as well. So we would like to find something that would provide safety and yet minimize the problems associated with toxicity and damage to the tissues. Obviously, in this slide, they've shown that saline is very safe. Obviously, that is a situation that everybody would agree with, but whether or not it actually does what we want it to do is another question. And certainly it doesn't have any significant toxicity when we put it in a wound. If we look at just the other side of the coin, as we have mentioned, you have products that may not be as safe, but then are pretty efficacious in cleaning the wound or managing bacteria. Some of the traditional ones that we know of are course of Dakin solution and some of the other blended synthetic solutions that are available on the market. And again, nearly all of them have some degree of problem associated with toxicity and damage to the cells that we use. So if we use them, we want to use them sparingly, but hopefully we can find something that will allow us to not have to compromise over either safety or efficacy. Maybe we can find something that will do both for the patient. One of the things that we look at that may be of benefit to prevent us from having to compromise is the way the body takes care of pathogens and bacteria. When a white blood cell tries to get rid of bacteria, this is the way it does, and you can see the illustration there on the left-hand side of the screen. The pathogen is identified by the white blood cell, usually a neutrophil. The neutrophil approaches it and then sends out these little pseudopods, or like a pincher. It goes around and engulfs the pathogen and pulls it into the cell itself. As it's pulled into the cell itself, it forms a phagosome around the pathogen, which is similar to just putting it inside of a balloon. That way it's not involving the remainder of the nucleus or the cytoplasm of the cell. It's just isolated from the remainder of the cell, but the cell has it under control. The neutrophil then will release hypochlorous acid. That's the chemical that's normally in the body, in the neutrophils, to kill the pathogens. It's released into the bubble, if you will, the phagosome, and its action on the bacteria results in it being removed. Then, because you have a lot of dead parts there, the phagosome is pushed out the other side of the white blood cell, and those dead parts are removed by the body. So you can see that it's a fairly efficient way of removing pathogens and bacteria from our cells once they get into the body. But the actual part that sort of removes them is hypochlorous acid that's generated in the body itself. This would imply that we might want to use hypochlorous acid in the treatment of topical wounds and things along those lines to clear the wounds and help healing. And maybe it will keep us from not having to make the choice of either efficacy or safety. And that's what's suggested by this slide. One of the things that we can look at is the pH of our wounds. I'm sure everybody has heard about wound pH, but I doubt any of you actually measures it to see how it affects your wound healing or where you stand with the pH. But interestingly, pH is a very significant problem when we're looking at the treatment of wounds. Because if you look to the right on this slide, you can see it says chronic wound there, and the pH in that bar shows that it's the pH of the chronic wound bed is between 9 and 10 many times. The normal pH of skin, as you can see down there a little lower, is between 5 and 6. It's slightly acidic. But when we get a chronic wound, the pH goes quite high, and many times this will slow the healing. You can see an acute wound, or one that heals very quickly, usually has an acid pH of 3 to 4. As the wounds heal, either one, chronic or acute, then the pH returns toward the normal skin intact skin pH at 5 to 6. So if we can return that pH to that area, it looks like that we're going to have a better chance to get the wound healed, and it will help other processes with the healing. As you can see on the left side, there are things that have to go along with that. The protease activity and oxygen release have to occur in the wound so that you can remove the abnormal collagen and the other debris that's there. By reducing the bacterial toxicity, the pH will also decrease. Angiogenesis is stimulated as we get the pH down a little bit. And as it says there, that the macrophage and fibroblast activity, things that actually close our cell, are improved as we get the pH closer toward normal. On the right-hand side of that blue bar with the numbers, you can see the solutions that many times are used for the treatment of wounds. And you can see their basic pH as they are applied to the wound itself. So many of them don't really benefit the pH of the wound bed. Again, this is part of the toxicity and the problems that we have using those solutions and not them healing the wound as well as we would like. We look at another situation here, a very similar slide, but it talks about the impact of pH on wounds. Many of the solutions that we use there contain chlorine, and that's one of the active parts of pathogen control. The increase of the pH decreases the ability of these solutions to remove bacteria. If the pH decreases, gets more toward normal or more acidic side, then the ability of these chlorine solutions to remove bacteria is improved. As you can see on the last bullet point there, that it takes twice as long for a chlorine-containing solution to kill when the pH goes just from 6 to 8. So you can imagine what happens when it goes from 8 to 10. So controlling the pH is really a big deal, and it helps with not only healing it protects the cells and encourages the healing of the cells. It also will help with the removal of pathogens from the wound. So we're looking at perhaps the best of both worlds. We want safety, but we want efficacy. And it's possible that the use of the hypochlorous acid solution will be of benefit in that situation. You can see the bullet points show that it's biocompatible. It doesn't really harm cells. It's friendly with fibroblasts and keratinocytes. It does not damage them or prevent migration. And it also has an effect on a wide variety of pathogens that could be found in the wound itself. Just some clinical and laboratory data. I know nobody's really interested in numbers and things like that, but again, let's see what we can show you and what makes some sense. One of the treatments that we have been using with these wounds includes ultrasonic debridement. If you have an ultrasonic debridement device, you know that ultrasonic debridement has to be utilized along with a solution that flushes the tissue and maintains the temperature. A lot of times people use saline to do that. We have used that in the past. And to use a saline solution for your ultrasonic debridement solution, you can see on the chart over there that if you start with an initial bacterial count of 10 to the 6 organisms per gram of tissue, as we know, they showed that after debridement with the ultrasonic debrider, it drops the bacterial count to 10 to the second. That's perfectly fine. That's where you want it, because we know that bacteria at that level are not a major problem. But you see, after 7 days after the debridement was done, the bacterial count has risen back to greater than 10 to the 5th organisms. And that's, again, a problem where we know that there's effect of the bacterial healing. If the hypochlorous acid solution VOSH was used in this same situation, they started out with the same bacterial count, and after debridement, the same bacterial load was noted at 10 to the second number of organisms. But 7 days after the debridement was done, you can see that the number of organisms is still at 10 to the second, well under the limit of needing attention for bacteria. This seems to be a clinically significant situation if you're using ultrasonic debridement. This also showed that when the wound was prepared to put a flap of some type on that wound, you can see that the failure rate was significantly higher when the ultrasonic debridement was used with saline as opposed to when it was used with the VOSH solution. The implication is that by keeping the bacterial burden down, that the flap healed a lot better and quicker. Another treatment of choice is using the negative pressure wound therapy now with installation, where they alternate application of fluid along with the negative pressure. You're familiar with that, I'm sure. This is a study where they used Dakin solution and saline as the instill solution. And you can see that the number of operating room trips showed to be about 7 during their treatment. The length of stay in the hospital was 25 days, and the days to closure of the wound averaged about 37 days. When they changed that instill solution to use VOSH, the hypochlorous acid solution, the mean operating visits decreased to 3.2. Half the number of visits were required when that occurred. You can see the length of stay decreased to 14 days as opposed to 25 days with the Dakin solution, and the days to closure decreased by 7 days when the VOSH solution was used as the instill solution in the treatment of these patients. Just some studies of interest that were done with this treatment of wounds with VOSH solution showed that the VOSH was very good in the treatment of these wounds and helped encourage debridement, as well as managing the chronic hard to heal wounds by penetrating the biofilm, which many of these solutions do not do, and helped get rid of the pathogen in the biofilm. The mechanical reduction of wound bioburden was important, as we've noted, and there was a cost savings associated with that. A couple of case studies that we would like to show you that can be illustrative of the situation. We show you how we do at our wound center. You can see case study 1. This is a stage 4 lesion that was neglected, After debridement for 4 weeks and daily treatment with Gauze Dressings, you can see the granulation tissue was quite healthy and the wound was beginning to show signs of closure. This is a worse looking case. You can see all the necrotic tissue that was there, but you can see that after debridement and 6 weeks of Gauze treatment on a daily basis, the wound bed completely improved, and you can see a significant amount of healing done in the wound itself. So in our wound center, we do use debridement. We use Gauze soap dressings as the antiseptic and to help cleanse our wounds. We are having a very good luck with that, and hope that you will consider that as you go forward. At this point, I'd like to turn the program over to Emily Greenstein, our colleague, who will show you some other cases and some other information about the use of hypochlorous acid in pressure ulcers and actually in other ulcers as well. Thank you very much for your attention, and I hope that this has been of information to you that will be useful.
Thank you, Dr. Treadwell, for that great presentation on the science behind Gauze. My name is Emily Greenstein, and I'm a certified wound and ostomy nurse practitioner at Sanford Health in Fargo, North Dakota. I'm going to talk to you today about a couple of case studies, just kind of showing you my experience utilizing the Gauze in patients that have pressure injuries, as well as in a couple of different patients with some different wounds also. So the first patient that I want to talk to you about, he was a 46-year-old male. He had a stage 4 sacral pressure injury. He had a medical history of MS, neurogenic bladder, obesity. He had underwent surgical debridement of the area, and at that time he had a colostomy placed. The wound initially was treated with negative pressure wound therapy for about 3 weeks. At that time, it was stopped because of the facility he was at was unable to maintain a seal on the dressing, which was causing a lot of periskin breakdown and a lot of issues within the wound bed. So at that point, we decided to put the patient on a protocol of utilizing an application of a cyanoacrylate, a skin protectant, around the wound, and then the hypochloric acid preserved wound cleanser, Gauze, moistened gauze covered by a dry gauze. It is important to note that this patient also did have a gel cushion in his wheelchair, and he was laying on a low air loss mattress. So you can see at day 1, when we stopped the negative pressure wound therapy, that the wound bed itself was fairly sloughy, kind of that stalled looking. The peri-wound skin was rather macerated just because they couldn't maintain a seal. And then if you look on the bottom picture, that is on day 90 of being on the protocol of utilizing the hypochlorous acid preserved wound cleanser as a wet to dry dressing, changed once a day. So the patient did have peri-wound skin significantly improved, and the size of the ulcer decreased, as well as the tissue in the wound bed improved. This is a patient. He was an 84-year-old male. He had a history of a stage 4 pressure injury. His history was significant for a non-STEMI. He had a cabbage. He unfortunately had developed this stage 4 pressure ulcer after he was admitted to the hospital for COVID-19 pneumonia. He underwent surgical debridement of the area, and he had a colostomy placed. We do recommend for all of our patients who are incontinent and have pressure injuries near the rectum or on the sacral area that they do undergo colostomy placement if possible, just to keep the contaminants away from the wound. This wound was treated with negative pressure wound therapy for 4 weeks. At that time, it was stopped because, once again, we had a facility that was having a hard time maintaining a seal. The wound did develop an odor at this time. The odor is often characteristic of the treatment of negative pressure wound therapy when you're unable to get a good seal and the bacteria starts to grow in the wound. So at that point, we discontinued the negative pressure wound therapy and started the patient on a similar protocol of the cyanoacrylate around the wound, the wet to dry dressings with the hypochlorous acid preservative cleanser or wash, and then covering it with dry gauze, changed once a day. You can see at the 4-week when the negative pressure was stopped that the wound had pretty significant overgrowth of hypertrophic tissue within the wound bed. And then you can see at day 90 that the wound itself was almost completely closed. We did end up treating some of the hypertrophic tissue with silver nitrate, and you can see that in the bottom picture, we use that for a chemical cautery type action that helps control some of that hypertrophic growth. The next patient, this is the patient, she was a 69-year-old female. She too had a stage 4 sacral pressure injury. She had developed it in the ICU after she was admitted for sepsis secondary to pneumonia. She had a history of diabetes. She had a traumatic brain injury. She underwent surgical debridement of the area and the ostomy placement, which is pretty standard treatment for these types of patients for our facility. She was then started on a protocol of the wet to dry once a day with the wash. Sitting was limited to 1-hour intervals 3 times a day. She did have an air cushion that she sat on. And you can see in the top picture, she was 30 days post-surgical treatment. And that's when we started the Bosch protocol. And you can see on day 90, she was actually completely reepithelialized. The next case I want to show you, he is a 55-year-old male. He had a stage 4 left ischial pressure injury. He has a history of paraplegia, CHF, hypertension, diabetes. He too underwent the standard treatment, surgical debridement, colostomy placement, and was treated with negative pressure wound therapy for 30 days. At that time, it was stopped because there was a little bit of breakdown around the peri-wound skin, and the patient was discharging from facility to home, and he just didn't think that he would be able to maintain or have negative pressure wound therapy at home due to his living situation. At that time, he was started on the protocol, which was, once again, the cyanoacrylate skin protectant around it, the wash, moistened gauze covered by a dry gauze, changed once a day. He had specialty cushions, and he was treated actually with the protocol for 60 days. He did end up undergoing a rotational flap for closure. So you can see the top picture, that was day 30 when the negative pressure was stopped. And then on day 60, when the patient was scheduled for a rotational flap, which was closed, you can see the wound had significantly decreased in size. He elected to undergo a rotational flap just because of his history of paraplegia, and he spent a lot of time sitting in his chair and working still. So he wanted something that was going to allow him to have a little bit more tissue coverage of the defect area so that he would have better outcome in the long term with his sitting. So this is just kind of a summary of those patients so that you can see it visually in a chart. So all of the patients had stage 4 pressure injuries that were previously treated with something else before switching to the protocol of the wash over dressing changes once a day over that 60 to 90 day period. You can see that at day 30, they were significantly decreased all the way down to day 90. They were pretty much healed. So now I want to talk to you about a couple of different types of ulcers that I've had really good results with utilizing the Bosch treatment for. So this is a patient who had levitoid vasculopathy. He was a 54-year-old male with a history of polymyalgia rheumatica. He was on a low dose of prednisone and also received IVG/IVM infusions. He developed an open area to his leg. He stated that he thought it started like a bruise. This was biopsied and confirmed levitoid vasculopathy. So this protocol that he was started on included being soaked with the wash for 10 minutes with each dressing change. He was treated with various topical dressing changes. So you can see on day 0 how he progressed all the way up to day 60 and beyond, and ended up going on to heal. The reason we chose this protocol, and the reason I choose this protocol for the patients who have these autoimmune linked disorders, is because they are high risk for the development of infections. Their immune systems are compromised either because of the autoimmune disorder or because of the treatment that they're receiving to suppress this disorder. So this patient did go on to healing. He also did not develop any signs of any infections during the treatment. This is another patient who was also biopsied as livedoid vasculopathy. She was a 68-year-old female that had a significant history of scleroderma, osteoporosis, Raynaud's. She was on long-term use of prednisone. She was also on Treadwell and FACCWS. She developed an area to her lateral ankle. She thought it started when she hit it on her bed. She too received the 10-minute soaks with each dressing change. She had previously had a history of developing significant supra-infections in this area prior to initiating this protocol. So you can see on day 0, we started the soaks, day 30, day 60, and day 90 that it did progress. She did not develop any infections during this time period that she was on the protocol either. Now, this is a patient, he has pyoderma gangrenosum. So this is another autoimmune linked disorder. He was on the immunosuppressants Cellcept and Dapsone. He had developed this area on his right leg. It started as a blister. He was biopsied positive for pyoderma gangrenosum. Unfortunately, some of the prior treatments that he received, the wound did get a lot larger. He, as a lot of you know, with pyoderma gangrenosum, there is that risk of lethargy or the wound it was spreading when there's any trauma to the peri-wound skin. So you can see when we started him on the protocol, day 0, day 30, day 60, and then day 90, he was almost completely reepithelialized. This patient also had previously had some infections, some issues with having overgrowth of bacteria in his wound and developing these infections. Once we changed him to the protocol, he did not have any signs or symptoms of any infections while he was on the protocol. This is another patient that had pyoderma. He was a young guy. He was only 33 years old. He had a history of Crohn's disease. He had in the past been treated with several different things systemically, but currently he was being treated with Remicade infusions. He was a patient of mine for a long time. His pyoderma was classic. He would hit his leg on something, he would run into something, and the area would immediately turn black and open up into a large wound. He had lesions on pretty much every extremity of his body at some point in time, on his abdomen, on his buttocks. This time when he came in, he had an area that was turned black after his dog jumped up on his leg. He was started on the protocol of the Bosch soaks for 10 minutes with each dressing change. And you can see with him, day 0, day 30, day 60, day 90, that the wound continued to progress. There was no signs or symptoms of any peri-wound maceration. There was no signs and symptoms of any infection or inflammatory changes that were going on. The patient went on to heal great. So kind of the summary of all of this, I have found that utilizing the hypochloric acid preservative cleanser can be a significantly great tool to add to your pressure injury treatment bundle or to your protocols. Like I said, we develop protocols that include soaking or cleansing our wounds with the Bosch for about 10 minutes with each dressing change. We have found, as you've seen on those last few cases, those patients that are immunosuppressed or at high risk for the development of infections with this protocol did not develop any infections and did not have any further complications. So just keeping in mind that this is a great option for those patients too. What it does is it helps to just cleanse the area, bring down some of that bioburden, kind of help the wound to get healthier. It does a really good job at preventing those supra-infections from forming in your patients that might be on immunosuppressants or might be at higher risk for developing infections. So thank you so much for your time, and now we will go ahead and take some questions.
Good morning, everyone. I hope you can all hear me. My name is Debashish. I'm the head of medical affairs for URGO Medical North America. Really a privilege to talk to all of you today and answer some questions. A particular privilege to be able to talk to Dr. Treadwell and Emily Greenstein, who are absolute luminaries in their field of wound healing here in North America. So many questions have come in, and I'm having a real tough time deciding which ones I should pick. I can assure you that 100% of your questions will get answered. The question is when we answer it. So let me start off by some excellent questions that came in. Now, Dr. Treadwell, spent some time describing the effect of or the relationship between wound chronicity and pH. And an excellent question came in: how do you measure pH in a wound? That's a great question. It's difficult to do. All the papers that have been published on pH and wound healing are mostly done in academic centers, and they have used somewhat sophisticated and generally not available methods to the clinician in clinical practice to measure pH. I know companies are working towards creating instruments that can measure pH. This continues to be a challenge. It's a great question, but there's no great answer to it. The second question that came in is hypochlorous acid. Now, it seems in Canada, hypochlorous acid is a new type of product, or hypochlorous acid preserved cleanser is a new type of product. And surfactant-based products and PHMB or polyhexanide-based products have been available for a fairly long time. So the question is hypochlorous acid safe, and why? I'm going to just expand on this a little bit, and then I will throw out some questions, put some questions to your clinician friends here. Hypochlorous acid, as was mentioned by Dr. Treadwell, is present in normal homeostasis and very important in infection handling in living mammalian systems. So from an evolutionary perspective, hypochlorous acid is dealt with in the body, and it's therefore extremely safe if used at proper concentrations and in a properly formulated product, which is true for VASH. The question that I have for Dr. Treadwell and Greenstein, and I will ask them sequentially. What is the patient experience that you want to note, Dr. Treadwell, from your side? What do patients tell you with respect to their quality of life issues when they use VASH? What do they tell you?
Well, let me back up just a little bit, if you don't mind. You talk about measuring pH, and there were a lot of questions about that. Obviously, as you mentioned, there are very special devices that will measure pH. In our wound center, obviously, our hospital wouldn't spring for those big fancy devices. So you can still use litmus paper like we did in chemistry lab. It works really well. It's a qualitative assessment, but it will give you a pretty good idea as to what your pH of that wound is. And the wound fluid, you just moisten the litmus paper with your wound fluid, and it will turn different colors. I would encourage you to find some litmus paper that's a little more reliable. They come in all different kinds. The kind that we had in chemistry lab probably is not the best, but we have some that's really good down to just about 1/100th of a pH point. So we get pretty good ideas with that. So I would encourage you, if you want to look at that information, then you certainly can do it in anybody's wound center. pH paper is very cheap, and you can get it, and your hospital laboratory might even share some with you. There are pH indicators on urine dipsticks. and all other kinds of things. So I would encourage you that you can do this if you want to do that. But as you mentioned, what are we trying to do with the patients? Well, the majority of the patients that we wind up treating with the Vash solution have a lot of extra drainage, and many times they have a lot of odor. I remind people that most of the odor comes from the bandages themselves, and not particularly the wound many times. But the important thing is that we want to improve the quality of life by trying to reduce the drainage and any odor and other problems. We found that using the Vash in conjunction with other dressings and bandages will help do that, reduce the drainage and also the odor associated with the dressing changes. Sometimes you need to change the dressing just once a day, sometimes more than once a day, depending on the amount of drainage. But the people that have had this used for them have all been very happy that it's that they've had a good outcome, and it changes their quality of life to a better quality of life for them at this point.
So, Emily, question for you, very similar. Your patients have acute injury, or they have more serious wounds. That's why they're in the hospital. Do you have any quality of life comments the patients tell you when you use the cleanser on them? Or do you have any commentary on that?
Not really. So I kind of agree with Dr. Treadwell. The patients, they're going to report improved quality of life. And on the inpatient side, we do get a lot of reports from the nurses saying that they like to utilize it because it does help with that odor control a lot. So the patients do like that. It also is easy to use. And then the other thing that I kind of want to add is, because I do see a lot of questions in the chat box about how we use it or how we do the compresses or soaks. So generally what we do is we just put it on dry gauze, get it really wet, and let it sit on there for about 10 minutes prior. With the hypochloric acid cleanser, I don't think there's an actual time frame. We just picked 10 minutes because when you look at all types of cleansers, the average kill time for all bacteria is 10 minutes. I believe with the Vash it is a little bit earlier, but it allows me to get everything gathered while they're soaking and interview the patient and kind of do some of those H&P questions also while they're soaking.
So, yes, you're right. There were a lot of questions about how long do you soak and things of that nature. As it happens, I'm going to share my screen with you and show you one particular document, which is a collection of all the peer-reviewed evidence that we have. And this particular paper that I'm showing you is a collection of 70-odd citations or references. That's the evidence base on Vash and hypochlorous acid. As it happens, in vitro tests show that approximately, now of course, germs die when they come in contact with hypochlorous acid in seconds. But when you have biofilm involvement, you have necrotic tissue involvement, 5 to 10 minutes of exposure seems to be the sweet spot with respect to time of exposure. So to all the attendees, I'll make this document available at request. So you can read up all there is to read about Vash and hypochlorous acid. Needless to say, there is a lot of peer-reviewed published evidence, both in vitro, preclinical, as well as clinical studies. Now, there's one more question that came in. What is the difference between cleansers that contain surfactants or polyhexanide and Vash? Vash seems to contain hypochlorous acid and no surfactant. Does that matter? Will that reduce the effectiveness of the cleanser? So there are 3 or 4 questions along the same line. Let me address it this way, that surfactants can be dangerous to cells. Surfactants are essentially soaps or detergents, and if they are present in high concentrations or too long in the wound bed and not rinsed away, they will disturb the lipid bilayer that keeps cells alive. And so we prefer not to have surfactant within Vash. Now, does that mean that compromises the cleansing ability? We do not believe so. In fact, we do see a big difference or big benefit in cytotoxicity being heavily reduced with the hypochlorous acid-based cleanser compared to PHMB containing products. Certainly, one question was about Dakin solution. Should hypochlorite containing Dakin solution be continued to be used? Knowing what we know, based on the preclinical studies that I can share with you, it is dangerous. Hypochlorite is unsafe at any speed and at any concentration, particularly because it is associated with very high pH. Dakin solution comes at a pH of 10. And anything that alkaline that you put into the wound, you may get rid of the germs quickly, but you're also going to get rid of the fibroblasts and keratinocytes rather quickly. And you don't want to do that. It's all about balance. Let me ask one question about is VASH compatible with other antimicrobial products? And this question is for Dr. Treadwell. After cleansing with VASH, do you use antimicrobial therapy or antibiotics or antimicrobial barrier dressings? Do you recommend the use of that, or, you know, how do you answer that question, Dr. Treadwell?
Well, generally, if we're just using a topical, we'll just use one topical. Mixing different topicals has never been really one of my things because you really never know how the two products are going to interact. So if we have a topical problem and we will use, if we choose to use VASH, then that's what we would do, and use that alone. If we needed other antibiotics or something like that, then normally we would use systemic or oral antibiotics to complement that. But we generally do not use two different types of wound cleansers at the same time, just to prevent any interaction and added toxicity.
So this question also can be addressed from a chemistry perspective. And as a chemist, I will answer what seems to be commonsensical. VASH and hypochlorous acid, it is quick acting. And, you know, exactly like Emily said, about 5 to 10 minutes of soak seems to do the job with respect to microbe removal and biofilm and necrotic tissue removal. After that, you can just pat the wound dry. The hypochlorous acid is gone, as opposed to surfactants and, you know, other long-lasting antimicrobial preservatives like PHMB. Just patting it dry will get rid of the hypochlorous acid. Once you're done with patting it dry, you don't have to rinse it. You can use any antimicrobial barrier dressing on it if you like. You can use a silver product, a gentian violet containing product. There is no compatibility issue because once you pat it dry, the hypochlorous acid ingredient is gone. Question for
You misspoke here. You said pack the wound dry. We do not recommend packing the wound dry for any reason, anytime, because that kills cells. And so you use a moisture retentive type dressing in that wound with or without the VASH, but you never pack a wound dry because you are doing more harm than good anytime, anywhere. So we want to be very careful with that.
So you're putting advanced moist wound healing dressings on the wound after VASH treatment. That's what you're saying, Dr.
Absolutely.
Okay. So that makes sense. Question for you, Emily. NPWT and installation with VASH. I think this is done on the inpatient side and not on the outpatient side. What has been your experience with that, and how often is this used in a big hospital like you? Can you comment on that a little bit?
Sure. So in the last couple of years, the negative pressure wound therapy with installation has become more and more popular because it helps with some debridement of the wounds. It helps to break up biofilm faster than regular traditional negative pressure wound therapy, especially in the inpatient. And it is only indicated for inpatients right now, or approved. We have used the VASH in the installation. It is approved for that. You might notice, though, if you do start using it, that your tubing can clog a little bit faster. And the reason is because the hypochloric acid preservative cleanser is breaking up some of that necrotic tissue and slough a little bit faster. So what's happening is it's coming off in a little bit more chunks, a little quicker. So kind of our recommendation, or what we do to treat that, is making sure that you're changing the dressing every 3 times a week versus twice a week, that you're doing it kind of every other day. Also making sure that you have the right amount of solution for the wound size. And if you do look, there are different formulas that go by the volume of the wound minus 20% is kind of the ticket of the amount of installation fluid that you're going to have. Other things, running the cycles a little bit faster, so more cycles versus instead of the 3-hour wait, maybe running them every hour to kind of help clean up or help loosen up that necrotic slough, so it comes out a little bit easier, because as we all know, the ports in those machines are pretty small. But we have seen really good luck utilizing the Bosch through the installation. The wounds, they do clean up a lot faster. There's a lot less odor. In some cases, especially with those patients that are not really surgical candidates, that they're not able to go to the OR. Or we've also had really good success using it in patients who are prepping to go to the OR. So an example of that would be your patients who have infected total joints. So we have patients that have infected total knees. They'll take the joint out for a few days. We will do the installation of the wound with the Bosch for a couple of days, and then they will end up going back to the OR to get the joint put back in. And we've seen some pretty good success with that as well.
So another great question regarding other cleansers have come in, and somebody asked, I won't name brand names, but they use a PHMD containing product. And why would VASH or hypochlorous acid preserved solution be a superior choice? I would answer the question this way, and I will share some papers with the person who asked the question. PHMD-based products, for example, were used quite heavily with installation about 5 or 10 years ago, but that usage reduced because of cytotoxicity concerns and because no particular measurable benefit could be seen. In our own published papers, where we have done head-to-head studies, we see massive differences in cytotoxicity between VASH, polyhexanide or PHMD containing cleansers, and hypochlorite containing cleansers, which may have small amounts of hypochlorous acid. And for those latter products, the pH is high. So of course, we see big difference in cytotoxicity. I will repeat that our view is that you don't have to compromise. You can balance your needs of germ and biofilm removal and necrotic tissue mechanical removal versus preservation of cellular life in your wound that is optimal for the wound. One more question that came in is, any concern with exposed tendon or bone with VASH compress? Dr. Treadwell, do you have in your practice tendon and bone exposed in wounds that you have treated with VASH? Can you comment on that?
Yes, we do. And we don't have any problem putting that on exposed tendon or bone, as long as we do not allow it to dry out. There's been some discussion about using this wet to dry. You want to keep it wet to moist. You want to change it before it gets completely dry. Or if you need to, then you could actually put some moisture retentive type dressing on top of your tendons and bones to preserve that, because you sure don't want that to dry out. So yes, we do. We'll clean that up as well, and help stimulate granulation tissue growth across the tendon and the bone as well. So we encourage you to use it gingerly. Everybody's a little bit different. You just have to play it by ear and see how your patient responds to that therapy. But as long as you don't allow the tendons or the bone to dry out and desiccate, then we have no problem doing that.
Yeah, so thank you. I just want to re-emphasize, I think Dr. Treadwell made it abundantly clear that drying of tissue is a bad thing. You're going to kill them. So don't let your bone and tendon dry. Now, research has shown that hypochlorous acid and is safer to osteocytes and to other cell types that usually are not talked about in wound healing. But to let you know that VASH is actually cleared by regulatory agencies to be used on stage 4 pressure ulcers. And those are famously full of bone and other structures. And so this risk has been assessed by regulatory agencies, and they think it is perfectly safe to use it that way. Emily, I suspect you see bone and tendon exposed in your wounds and you're using VASH on them quite frequently. Would that be a correct assumption?
Yep, that's correct. And kind of the same thing like Dr. Treadwell said. And we especially see it a lot more in the inpatient setting. And those are the patients that we would utilize it through the installation, the negative pressure wound therapy with installation, probably a little more frequently, just to get those cleaned up more, and so that those don't dry out.
So one question that came has to do with peri-wound protection when you're using VASH. Or do you take any particular steps, Emily, on your patients? You mentioned cyanoacrylate a couple of times. Does the cyanoacrylate have to be reapplied or replaced when you're using hypochlorous acid?
Sure. So I'm a big user of cyanoacrylate products, just because they do a lot better job of peri-wound protection. Anytime that you're dealing with a wound, you want to have good peri-wound skin protection. Especially with the VASH, you kind of need to see how much the wound is draining. For our patients with the cyanoacrylate, it can be in place for up to 7 days. If the wound is draining more heavily, though, we do apply it every 3 days about. But a lot of times we use it under compression wrap. So we'll do the cyanoacrylate around, we'll do the protocol actually as the patient will come in, we'll do the soak with the hypochloric acid for the 10 minutes. I'll do sharp debridement, then we'll rinse it with the VASH and then pat it dry. And then we end up using a topical dressing of some sort to maintain that moist wound healing environment, the cyanoacrylate around the wound, and then a compression wrap over it. That's kind of our outpatient protocol for our patients that have VLUs or diabetic foot ulcers.
One question for you, Emily, a follow-up from somebody. On the inpatient side, I think on the outpatient side, I know the answer. So patients are asked to change or cleanse the wound daily at home. But on the inpatient side, it seems like you can, or you want to put a wet to dry VASH soaked gauze and change it, never allowing the wound to dry. But how do you decide when to change? Whether to change it daily, whether to change it 2 times a day, 3 times a day, because your practice is variable, you have told me. Can you explain how you decide when to change on the inpatient side?
Sure. So on the inpatient side, a couple of things that we look at is the amount of drainage, what the wound is from, and what they, so for example, if you have a patient that comes in and they have an infected wound or like necrotizing fasciitis, those ones obviously are going to be changed a lot more frequently. Those are changed probably up to 4 times a day, just to make sure that we're continuing to debride, continuing to clean out that bacteria. And then the ones that have a lot of odor, those are changed a lot more frequently as well. So there's a lot of factors that play into deciding how often you're going to change it. I did see a couple of questions asking why we would choose this over something that could be changed less frequently. And kind of the rule of thumb that I use is that sometimes wounds need to be assessed, especially in that acute phase in the hospital. They need to be assessed more frequently. So doing more frequent dressing changes. Also, just because some of those wounds have such high bacteria or biofilm, bioburden in them that they need to be changed more frequently. Wounds that have a lot of slough or eschar in them need to be changed more frequently, just to make sure that you're continuing to debride that frequently. Once the patients go home or to the outpatient side, we do tend to look at something that can be changed a little less frequently, but at that point they're kind of at where they can probably do it once a day or maybe twice a day.
Well, thank you so much. I think, the questions keep coming. We'll answer 100% of those. I want to thank both of you for a great session. I will send the reference list to everybody. Again, this has been a great session. Thanks to Wounds Canada. Never compromise. I can't emphasize the point enough. Cytotoxicity, pay attention. Thank you. Have a great day, everybody. And please visit our booth and you can get information on how to get this product should you want to use it. Thank you again. Have a great day.
Thanks.